Take it away, Jeff.
Good afternoon, everybody. This is Jeff Weinberg, the president of Caregiver Champion, and we are proud to have a special guest today in our series of getting to know different services and people who are running those services. Unfortunately, some of my people have died recently, and some of them were prepared for the death, and others were not prepared for the death. And it's been something, especially with everything going on with COVID, that has been extremely harder to deal with than death in general, which is hard enough to deal with. Some of you know this, some of you don't, but my own mother-in-law died in a nursing home actually a year ago, close to today. And she died alone. My wife couldn't come in and visit her. And she actually had lived in Florida. So we had a funeral that was in Florida through Zoom, because nobody could get on a plane and go there. And in some ways it was really good, because we had people from all over the country and all over the world, actually, from Israel to England to America, attend the service. But in another way, my wife just said this yesterday or the day before, she still doesn't feel like she's gone through a grieving process. And that's a very sad thing. So I've been fortunate. I've worked with a number of hospices in the past. And most of the time when I bring up hospice, the people go, I don't know what that is. And, you know, this is real confusing to me and things like that. So Nikki, who is a nurse who I've worked with most recently, has a very good grasp of hospice, has a lot of experience in the field, although she looks a lot younger than she is. And I'm proud to introduce Nikki Ghate, and with Suncrest Hospice. And without further ado, we'll move on. One thing I do want to wish you is a happy Nurses Month or week, whatever nurses celebrate these days. As an administrator, they never gave us anything to celebrate. They just said keep on working. But I'm very proud of the nurses that I've worked with. They're truly dedicated people to the field, highly professional. And as we've talked about COVID, it's been an extremely difficult time for our healthcare people. And so Nikki and every other nurse, you truly are a hero, and God bless you for what you do.
Thank you. Thank you.
Yeah, ditto to all of that. Thanks for joining us today, Nikki. Let's start off by hearing about your background.
So I'm actually a clinical hospice liaison with Suncrest Hospice. I've actually been with them for about almost a year now, June 1st. And I've been a nurse for the last 10 years. My background is through skilled nursing. I've worked in different roles as a quality assurance nurse, regional role, liaison. I've also worked in specialized stem cell clinics for lung patients, end-stage lung disease. And so I've actually been that nurse that's actually experienced the side of administering hospice care, but I've also been that liaison that has gone through the community and talked about it. More really going into focus of letting people know that the misconceptions of what they hear about hospice is not the truth, and trying to get those myths squashed out.
Yeah, absolutely. That actually leads into our next question, which is, you know, there is a lot of confusion as to what is hospice. So can you further explain to people, you know, what it is?
Yeah, one of the best ways I describe it for hospice is the hospice of 10 years ago is not the hospice of today. when I was hospice, when I became a nurse 10 years ago, one of the things that I noticed most of the time were patients coming onto service that were actively dying at the start of care. So that has since evolved over the years. Some of the things that we notice now is that the patients coming onto service are more alert and oriented, and they're able to still do a lot for themselves, cooking, shopping, driving. These are things that you look at someone on the outside and they don't look like they're hospice appropriate, but really it's about the disease process. So we look at these disease processes that we know they're declining. We know that there's a progression of decline, and we know there's going to be a threshold that they're going to cross over soon. So once they start to hit that threshold and they are declining evidently, then that's when we say, okay, this is time for hospice care, or we need to have that talk. So hospice really, what it is, it's a goal, or it's talking about the goals of care. It's talking about what we're going to do for your end of life, and then what we're going to do to help the family and the patient navigate the medical, emotional, social, and spiritual details to ensure they're focusing on that quality of life rather than getting the aggressive treatments that would otherwise cause a faster decline. And some of the things that I hear most with hospice is, I wish I would have known about you sooner. And when we hear that, we really encourage an early start. Of course, you can start hospice anytime during the disease process once you have that diagnosis handed to you, and the physician says, unfortunately, you've been given a diagnosis of 6 months or less. So what we do with hospice, it does involve a large team that's really focused around the patient and the family. And I tell everybody it's really about the family too. It's not just about the patient. Sometimes patients don't let go until they know that their family is going to be well taken care of. So we really have a good psychosocial part that and that is involved with hospice care. And that's involving the chaplain, the social worker, and a bereavement coordinator. As Jeff was actually talking about his mother-in-law passing, and that just kind of leads me up to really focusing on bereavement and grief, because working through that grief period is key. Part of the other care is the clinical side. So that's going to involve your medical director, your RN case manager, and your CNA. They're focusing on what's going on physically with you. And they're also going to continue coordinating with your primary care physician. We notice that it's better to continue with the primary care physician that you already have because you have better outcomes. So we collaborate together with that. Like I said before, eligibility is going to be based off of having a diagnosis of 6 months or less, but that doesn't mean that that's always the case. Even though as medical professionals, we say you have the 6 months or less, it doesn't always line up that way. We don't always get it right. We can say that this is what the prognosis looks like, but we have seen cases where somebody goes beyond that 6 months, or they sometimes graduate from hospice.
Yeah.
Nikki,
Yes.
how important is advanced directives? Because I know when I work with people, lots of times, again, they don't know what an advanced directive is. And then when we talk about hospice, they really confused.
Absolutely. We actually tell people that just because you are going on a hospice, by the way, doesn't mean that you have to be a do not resuscitate, and that you have to completely choose no care or comfort care. So I know that's one of our other questions we're going to talk about. But I have seen cases where patients do not have an advance directive or no living will, and there's been complications amongst the family deciding what to do for that loved one. It does make the situation a bit sticky, but we're there to help them out with that. So I do let everyone know that once you do have that diagnosis and you're told that your prognosis doesn't look great, even before then, even myself, I actually have put advanced directives in place and I'm pretty healthy. So it's just letting people know what you want at the end of life, or if something happens to you and you can't speak for yourself anymore. So I do let people know it does help to prevent the stickiness amongst the family.
I think that's so important because families who aren't aware of what their relative or loved one wants really are in conflict as to what to do.
Absolutely.
Now, just for example, my living will says that I want Ivy by chocolate, and then I'm out of here. And my and I have my daughter actually as my advocate for that particular part, because she's in healthcare and she understands that. And I know that for my wife, it would be an extreme conflict for her to do that.
Absolutely.
Maybe it wouldn't be. I don't know. It depends on the day, I guess.
I will say that sometimes talking about living wills and advanced directives, when you're making that selection of individual who's going to make the decision for you, a power of attorney, medical or financial, sometimes you choose the person that is not as close to you as you thought you would probably choose, because that one, like your spouse, may actually want to go against what your wishes are because they don't want to let you go. So
Exactly.
I do see cases where the decision maker happens to be someone that's kind of taken out of the equation and they have a clearer head to make that decision for you.
Yeah, that makes sense. That's interesting. You touched on it a little bit, but what is the difference between some of these cares, comfort care, such as palliative care and hospice?
So comfort care in general is when a patient can decide they no longer want aggressive therapies or treatments. They only want comfort in their current settings. That can be broken down into multifaceted situations. And some of those situations could be they no longer want a medication that may be taking care of their heart, their blood pressure, or any other internal factors. It doesn't mean just that. It could also mean no surgeries, no hospital visits. It could mean no doctor visits. It means that all they want to do is just be home and that's it. They don't want to have any tube feeds. They don't want anything else to continue their life. But that does not mean that to be on a comfort care level, you have to be hospice. We have patients that we see all the time come across that are CMO, comfort measures only, and they're not hospice. But it could also mean that you are hospice. So it depends on that case. Then you break down into the palliative care. So palliative care reflects on symptom management. That's for anybody with or without a terminal diagnosis. So it could be anybody from any age, any range of age. It could be anybody with any range of disease process or illness. You can use palliative care on a pregnant woman who has persistent nausea, vomiting. If they have hyperemesis gravidum and they need to manage that, that's palliative care. But that doesn't mean they're dying. So it really reflects of what you look at as far as symptoms are concerned. It could be something until you're just cured, but then it could also mean that maybe once they get to that point of trying to continue palliative care, you can't control it anymore, and they talk about hospice being the next step. So hospice, as we talked about before, would be electing into the service, but it doesn't mean you're dying now. We have to really, really talk to people about that, because unfortunately, like I said, it doesn't mean you're dying now. It doesn't mean you're either giving up either. It means that you're really focusing on your quality of life. You want to really be comfortable and you want to live the best days, the remaining days out, and ensuring that your family and yourself are taken care of rather than focusing on the disease.
Yeah, that makes a lot of sense. Who is it that pays for hospice, and do they cover everything?
That's a couple different breakdowns of that. So hospice actually is covered by multiple different types of insurance plans: Medicare, Medicaid, maybe HMOs. It can be specialized insurance plans. Sometimes we see other types of plans like Community Life or Lifespan or Life Pittsburgh come in and kick in and they pay for the hospice. But typically, let's talk about the Medicare benefit. That actually covers 100% of the care pending the location of the patient. And why I say that is because care can be done in the patient's home. It can be done at a skilled or a long-term nursing facility, an assisted living facility, personal care home, or a hospital. We can do a general inpatient stay. But what happens then, if they're in these facilities, it's going to dictate the additional costs that the patient or family would be responsible for, such as room and board. So whenever we do talk to families or patients at the beginning process of this and during an informational or we're setting up for services, we do tell them that you should speak to the facility in regards to the room and board. Typically, the facility's business office can discuss that with them and give them a breakdown. In some cases, what will happen is the Medicare could kick in and cover the hospice benefit. And if they have Medicaid as a subsidiary, that Medicaid will cover their room and board. Each case is different. So I always let everybody know, let's talk this out. They really need to be aware of what they're looking at. But if anybody ever tells them that, nope, you have nothing else to worry about in a facility, definitely ask the questions. The other thing about this is when you said, does it cover for everything? Medications, treatments, and equipment related to the disease process are covered under the hospice benefit. But if a patient chooses to start a medication or continue a medication that's not related to the disease process, then they would have to talk about that being an outside cost. I always tell everybody, let's look at other options to explore to prevent that from happening to you, or at least let's look and see what kind of costs you're going to be looking at out of pocket.
Right, right.
And I want to add to that room and board isn't cheap. It's about $300 a day.
Yes.
So a lot of people, in fact, I have a client right now that's going through this, and she isn't sure whether she wants to keep the person in the facility or bring them home, because it's so expensive to keep that person there.
Mm-hmm.
And so it's very important for people to realize that hospice does not cover everything, and that they still are going to have either some form of out-of-pocket expenses.
Exactly. And I do want to add on to what Jeff is talking about too. So keep in mind that when you have that decision being, do I bring someone home or do I leave them there? You're looking at your average of $300 a day for room and board. But if you bring your loved one home on hospice, that's wonderful. But if that patient needs 24-hour care, now you're looking at the potential of having to bring in a home care agency to help care for that one that's in your home, so that you're not experiencing caregiver burnout. So then you'd be responsible for the home care agency unless you have a waiver program to help pay for that program. That is one of the things that I personally like to help families and patients look at, and I'll put them in touch with individuals that can help with that or hire on that service.
Mm-hmm.
But to add to that, private pay for a home care agency on the average is $25 an hour. So that adds up very quickly.
Yes.
And it's kind of, it's important that people realize that as they're younger, actually, that getting a long-term care insurance policy and something like that in advance, when it's reasonable to pay for, really is protection, because again, going back to my mother-in-law, she went through a considerable amount of money before she ended up going to a nursing home, because she had 24-hour care in the home at $25 an hour.
Wow.
So the money goes away pretty quickly.
Absolutely.
You somewhat touched on this, but how do you qualify for hospice?
So based off of Medicare regulations, the qualifying for hospice is based off of a terminal diagnosis of 6 months or less. The physician actually has to certify that the patient has a prognosis that they're going to pass away or decline within that 6 months if the disease were to run its normal course. That could include that the patient no longer is seeking curative treatment, or the curative treatment is no longer effective. So again, it really reflects on that 6 month or less process. But again, I want to point out that it doesn't mean that they're going to die within that 6 months. We have seen cases where they go beyond that. And a lot of the reasons why we're starting to see that more and more now is because with hospice, we actually are able to catch symptoms a little bit quicker than if they weren't on service. So sometimes we're actually able to help slow that disease process down more than if they were not on hospice services.
Wonderful.
Can the 6 months be extended?
Well, you have to still continue to show a decline. So if they hit that research period that's beyond the 6 months, there still has to be documentation showing a decline during that point. we have actually had patients on service for over a year. And so when you're doing that documentation, the nurse is seeing them, the doctor's seeing them, the aide is seeing them. They have to say that this patient may be losing weight. They were still consistently losing weight. They are no longer able to ambulate throughout their home as they were once able to do when they first came onto service. Maybe they're no longer incontinent when they first came onto service, or they're no longer eating without assistance. So there has to be some type of decline that's documented if it's anytime they're doing their research. So it's not just the 6-month mark. They still have to show that during the point before the 6 months as well.
Do clients have choices as to what residents can pick?
Again, that's based off of Medicare, Medicare regulations. We have to give them rights and responsibilities. And what that means is that they have the right to say no, and they have the right to say yes. They have the right to decide on how they want to go out. We let them know that this is the end of your life. This is the way you're going to decide how you want to do things. So you need to tell us what you want, and we'll try to make it the way we try to make sure that they get most of what they can or what they're choosing to do, obviously within reason. There are cases that somebody wants to be somewhere in particular, and we understand that they need the 24-hour care. So we do talk to them about the pros and cons. So as long as we discuss that with them and they understand, we do let them decide, with obviously within safety reasons, of course.
Right. Is there anything else that you'd like to add that you think, people should know, or anything about your, specific place of work at Suncrest?
I do want to add on that just because a physician doesn't bring up hospice care doesn't mean that you can't talk about it or ask to talk about it first. So sometimes these doctors just don't talk about it, and then it becomes something that happens too late in the end. So if you think about it, you hear about it, and you want to know more, ask the doctor. Don't be afraid to ask that question. As far as Suncrest Hospice is concerned, we are located in Monroeville, but we go all over through Allegheny County, Westmoreland, Washington, Butler, and Fayette. We are slowly expanding. We've been around the area for about the last 2 years, and we have a wonderful, wonderful team. We actually call each other family members. So this is probably one of the best companies I've actually worked for. But if anybody has any other questions or ever wants to just call me and just talk more, I can be reached at through my cell phone, 724-610-2639, or they can email me directly at cghate@suncrestcare.com. And that's about it.
Great. We'll put that information in the link below this,
Awesome.
as well as Suncrest's website. Thank you so much for sharing all this information. I know I learned a lot, and we hope people listening learned from this. So thanks for your time today, Nikki.
I just want to add one more thing. First of all, thank you, Nikki. I always enjoy working with you. But I have to say, and she just raised a very good point. Doctors are very hesitant to talk about death.
Mm-hmm.
They want to save people's lives. And then when they get to the point where they can't do that anymore, they almost shy away from it. I've worked with doctors in hospitals and in nursing homes throughout my career, and even people who are oncologists have a hard time talking about death. So it is important that if you feel that you want to do a hospice program, that you ask the doctor or ask someone to have the doctor write that order. Mm-hmm. And then finally, just real quick, and my wife brought this up just recently, and I mentioned it, is even when someone is dying, they are starting the grieving. The relatives are starting the grieving process. And it's important for other people to understand that. And there are books about 5 stages of grieving and things like that. And I would recommend that anybody who's in that kind of process, and it doesn't even have to be dying, like for example, if your loved one has dementia, it's a loss, and you're dealing with that loss.
Mm-hmm.
You're still going to go through a grieving process,
Mm-hmm.
and hospice in particular helps with that tremendously while the person's dying, and as well as after the person's dying. And having a social worker and a chaplain involved from a spiritual perspective is just so important to the family. But again, thank you. You were terrific, and I
Thank
really
you.
appreciate you joining us.
Thank you very much for having me. It was great. Thanks.
Thanks, Nikki. All right, until next time, everyone. Thanks for watching.